again, I think COVID has shown even more clearly how important that integration is, that you can't actually promote good health and achieve good outcomes for health if the rest of, you know, the support and care that a person needs is not there. So there are obligations on all sides, but we know in practice this is really hard. It's difficult stuff. And sometimes there's been a sense that the contributions are not consistent, and they're not always well coordinated. So my team's working to try and support that from the centre. A lot of this is devolved. A lot of the action here happens locally. We're very aware of that. We don't make the system work. You all make the system work. But we are keen to try and do what we can from the centre to make that easier so that integration happens because of the policy context and not in spite of it. So if we could move on to the next slide, please. Thanks, Marie. Excuse me. Here we go. So a couple of stats for you. These are really, there's loads of data out there that I could have drawn on. I just grabbed a few, but some evidence of poor or variable performance, things that are not consistently good. Back in during the first lockdown, the Disabled Children's Partnership conducted a survey of families, which had a pretty big response rate. And what's really interesting here is the figure of 38 on the left there, 38% of families where they were in receipt of a respite service or short break before COVID, only 38%. So, you know, this is not universally working for all families. Now, obviously, there's differences in eligibility and entitlements, but I was personally surprised by how low that figure is. The Family Fund Trust have been doing some surveys with families that they work with or have accessed their information, and they found in September that 60% of children with SEND were still reporting that they weren't able to access all of the specialist therapeutic services they require. Now, before Lorraine shoots me down, or colleagues from the health side, I know that picture has improved since September, and it's improved quite rapidly, but it's evident that making all the bits work together is still really hard, and it's been made much more difficult by COVID. But some of this wasn't working all that brilliantly before, so that challenge has really exposed those difficulties. And when we look at area performance as a whole, during the 1920 academic year, which was obviously interrupted by COVID, 16 area inspections took place, which are joint inspections between Ofsted and CQC, and 9 out of those 16 resulted in the area having to produce a written statement of action due to serious weaknesses. That's obviously quite a high proportion. It's quite concerning. And in all 9 of those inspection reports for those areas, EHC assessments and plans were mentioned as being a weakness. Joint commissioning and co-production, also really frequent themes. So it's the bits about making it all work together which are proving the challenge. So carrying on, I don't want to take too much time up this morning, so we'll try and skip through some of these. So what have we been doing? I mean, it's been fairly busy, I would say, as all of you, I'm sure, can empathise. It's been that twin challenge of trying to respond to the difficulties of COVID and support the sector in recovery, but also keeping some of our business as usual going and actually rejuvenating some stuff that was paused at the beginning of the pandemic. So we've been working with the Department of Health and Social Care, who lead on the autism strategy, which is a document they're required to produce under the Autism Act. And that is reviewed and updated periodically. This year, for the first time, the scope of that strategy has been expanded to include children and young people explicitly within its scope. We're expecting that to be published in the spring. It has been delayed, but we've been working really hard on that to look at how can we work collectively to respond to the specific needs of children and young people with autism. And that document, although it's led by the Department of Health and Social Care, it's a cross-government publication. So there's all sorts of other things in there about other services which would be of benefit to autistic people and to better coordinate support across the piece. We're also working with NHSE on the Liberty Protection Safeguards, which is a specific scheme. It involves a very small number of people, but a very vulnerable and high needs cohort that we are all interested in meeting better their needs. So this is about young people who lack mental capacity to consent to decisions around their care and treatment, and where it's necessary to actually deprive them of their liberty. The legal framework for this group of young people has been complicated, and there are difficulties in ensuring that the right processes are put in place. When LPS begins to roll out, which we're expecting to be 2022, it's explicitly covering 16 and 17-year-olds. So trying to get the design of this scheme right, it's going to create new responsibilities for local authorities. It's going to be monitored by Ofsted and CQC through their area inspections. So there's lots of strands to this work. There's work around the data collection. There's things around workforce that we need to engage with. So we've been taking that forward. Again, this is one of the areas where we're working really closely with other teams in DFE, particularly across social care and our mental health teams. And then we're, as I've mentioned already, the area send inspection framework. We are due to launch a new one again in 2022, and we're working really hard. You're going to hear more about that this morning, I think, from Nick Whitaker from Ofsted. It's really exciting, amazing opportunity to really try and get to the heart of what do we want the accountability regime to drive in terms of positive behaviours? How do we support areas to improve their practice? How do we capture and respond to that work that you're all doing out there in local areas, and make sure that that is actually moving the system forward in a collaborative way? So, excuse me, really important piece of work, and we're working really hard with Ofsted, DHSC and CQC colleagues on that. Thank you, Marie. We can move on now. And then there's some work in specific areas. So social care, this is an interesting area within DFE, social care for disabled children, because, as you'll understand, a lot of social care, and this is true at local level too, it's focused on safeguarding child protection, and the short breaks and respite care doesn't always fit with that, because often this is about supporting well-being and promoting good outcomes for a family rather than responding to concerns. So the policy ownership for respite and short breaks sits with SEND division, even though notionally we're sort of on the education side of DFE. So we work really closely with our social care team colleagues, because they obviously own different bits of social care, like safeguarding practice, for example, which covers all children, not just those that don't have a disability. Work across the department, and it's quite a complicated area. It's been very challenging responding to COVID in this area in particular. I would say it's one of the biggest themes in the kind of feedback that we get from stakeholders that are talking to families and families themselves. The lack of respite care, the interruption to those services has been very keenly felt, and we are acutely aware of that. So we've worked at real pace as the guidance has changed and shifted. So initially we worked with CDC to gather some examples of good practice, some flexible working approaches that some LAs were developing, and we've tried to share that and disseminate good practice through the system using CDC and their networks. We want to continue to take forward those elements. We want to encourage local authorities to apply a flexible approach towards working within the regulations, particularly around direct payments, because we've heard directly from families that that can be really helpful. We've also tried to keep our guidance up to date. I'm not going to say that we've always managed that in a timely way. I'm going to hold my hands up and say that. It has been incredibly rapid how changes have been announced, regulations have been laid, and guidance needs to be updated. That process several times over has resulted in some very late nights and some very long days, particularly for government lawyers, so spare a thought for them. But we have now got to a position where we have a very clear legal exception, and it's specified in the regulations that services which are providing respite or short break for a disabled child or supporting their family are allowed to operate, and that message needs to be repeated and shouted and replicated as much as we can. We do not want to see providers worried that they're breaking the rules if they try to continue, so we thought we need a cover-all. There are various different exceptions. It's quite complicated a picture. We said to our lawyers, we don't want everyone to have to work out which bit of this legal framework they fit into. We want to just be able to say publicly and explicitly, if you are delivering respite care, you can continue to do so. And that covers services in the home and away from the family home. We also, in the last round of changes, had an additional support bubble category established, which is about supporting families with a disabled child under the age of 5, where they have continuing care needs. And the reason for that, again, was just to recognise that preschool, there is, very, very high demands on families that are caring for a child in that situation. And even where services are operating, it can be very difficult for a younger child to actually be able to go and access those services and give families a break. So having an opportunity to mix with another household and those support bubbles are permissive. So they are, it can just be about social contact for the family. It can be about emotional support. It doesn't have to be about delivering a specific service to that child. It can just be that actually mum and dad just need a cup of tea and for someone else to play with the little one for for half an hour while they just breathe. And that's absolutely fine. So again, we just really felt from our feedback, from the knowledge we have from the sector, that this was an important addition. Okay, let's move on, Marie. Thank you. Well, this slide has got stuck. Here it is. Brilliant. Okay, so a few more bits on the social care side that are perhaps moving us away from the immediate COVID response. We're working really closely with NHS England around admission avoidance, and again looking at our most vulnerable and sometimes most complex young people, those that may be at risk of admission on to a CAMS facility or Tier 4 bed. We're keen to explore further how community-based services, including respite care, can be protective. And there's a lot of discussion going on in the background around, how do we deliver therapeutic support? How do we deliver mental health and well-being support most effectively to our vulnerable children and young people? So there's a lot of work going on in that space at the moment. We're having also internally within DfE, we're having a lot of discussion about early help services at the moment and what that looks like and how we might be able to improve the offer, make sure that services that families are being referred into are appropriately specific to meeting the needs of a disabled child in the family, rather than always just offering generic services. And we're also looking at workforce needs. And we know there's a lot of input from the sector. There's lots of stakeholders that have views on workforce needs. We're looking at, good practice. We know that the CDC and others have been working, looking at post-qualification standards for social workers, for example. There's lots of activity in this area. And as some of you may know, we're working really closely alongside the SEND review team. So they sit alongside SEND division, SEND policy within DfE. They are a separate team just because of the amount of work, but we are very, very closely enmeshed with their work, and a lot of our input is feeding into the review. And there's also a care review forthcoming as well, which will look at, another opportunity to look at how social care services best support this group. And we're very much engaged in those conversations as well. Okay, on the health side, I attend a lot of health meetings. Lorraine will be aware. There are lots and lots of work strands going on, which is brilliant. The Autism and Learning Disability Programme, which is led by NHS England, is really, there's so much momentum behind this area of work, and I think that's really amazing. And there are specific commitments around autism in particular in the long-term plan. It feels like it's quite a different position from where we were a few years ago in terms of the attention that these services are receiving. And I know that health colleagues work really, really hard to keep the priority focus on children and young people within that all the time. So we are involved with that. So we're involved in the key worker pilot, for example. We're involved in various other work strands around improving services for that cohort. I also, with Sue North, who I think is going to be speaking to you shortly, co-chair the cross-system working group, and that brings together lots of partners from across the health world, as I describe it, because I can't keep track of all the different bits and all the organisations and all the acronyms. So lots of partners from that side. We also have parent carer representatives on that group and people with lived experience. It's a brilliant forum for thinking about joint programs and how can we work together to kind of produce something which is greater than the sum of its parts in terms of driving improvement. And as I say, referring back to that data at the beginning of the slides, we're working with NHS England Send leads on sorting out the access to therapies. I think it's now been published on the NHS England website. There was a letter yesterday from Suzanne Rastrick, the Chief Allied Health Professionals Officer, which gives really clear steer that these professionals need to be protected, and wherever possible redeployment in response to COVID pressures should be avoided, and that prioritising delivery of therapy services for SEND children and young people should be really, really high on the top of the list in terms of prioritisation going forward. So that's very positive, and it's in addition to a letter from Viv Bennett earlier on, which said the same thing a few weeks ago around nursing workforces, including school nurses and health visitors and midwifery. So that's really positive messaging that is raising the profile of the needs of this group of children, and we're really, really pleased that we've been able to get that messaging out there, and we know that that will be very reassuring for our families and also for schools who are generally concerned about the access to the wider package of support that their children and young people need. It helps them to sustain attendance and keep kids in school, which is what we want to see. So I know that's been really quick, and I've thrown quite a lot of information at you. There are quite a few questions in the chat which have been noted. Yeah, have you got a list of those, Amanda? I think that is the end, isn't it? I've not missed a slide, Marie. I'm really guilty of doing this, of thinking I've finished and then someone presses a button. It's like, oh, there's a whole other slide. Yeah, so I'll take your questions and deal with those now. But I also, if we could leave this up on the screen, Marie, that would be really great. I'm not asking you to come back on these now. This isn't a workshop. But I would like, it'd be really helpful to hear people's thoughts at some stage around these questions, because these are the things that we're really driving at. And if you would like to email me beyond this meeting with your thoughts or any kind of other bits of information, I'd be really interested in these. And I think these are helpful just to think about in the context of your own organisation and your own sort of area of work as well. Just thinking about really how can we bring that integration together to really drive improvement and promote consistency as well. But Amanda, do you want to go through the questions that have appeared, and I'll try to answer them?
So there were a couple. I think I saw that Caroline had put a link up. So Caroline, was that the link for the legislation around short breaks? Because
yeah, it's the link to the CDC website. We've got a page on the website that kind of analyses a bit of the emerging guidance around short breaks, what it means for families, what it means for providers and for local authorities. So we'll be updating that regularly as guidance changes as swiftly as we can. So that's a probably good starting place, and then it links through to the government pages for the different relevant pieces.
Okay, so that answers one of the questions, Janet. There was a question around so Sarah Derbyshire was saying flexible use of direct payments have really benefited families, and will these changes be locked in post-COVID?
I mean, I think ultimately that's probably a decision to be made locally. I think what we've sort of realised or reminded ourselves of is the regulations around direct payments are reasonable already. And where local authorities have taken a more flexible approach to the use of direct payments, that has been within the rules. We haven't changed the rules. There's been no legal changes at all to that area during COVID. I think what has perhaps happened over time, because the regs are a few years old, is that local authorities have sort of drawn up a series of criteria, and some of those sort of criteria sets are more restrictive than the regulations actually require. So I suppose the first port of call would be to say, have a look at your local authority's criteria and really sort of interrogate that against what the regulations do allow. And if you've seen examples of other areas that are taking a more flexible approach, I'm going to assume that they're not breaking the law. In most cases, certainly the cases that we've looked into, they are doing things which are allowed within the regulations. So it may be that some of those criteria would benefit from being reviewed. In terms of locking it in and saying, that this is an approach that has to be made, I mean, that would require legislative change. As part of the SEND review, we are talking about what the role of social care is and whether or not it is necessary to change any of the legal framework behind respite and social care. So that's a very live question. When the review is published, it will invite consultation. There will be further opportunities to comment. So it's not, we're not going to publish a bill. We're going to publish some consultation questions and the findings from the evidence that's been gathered. So I think if there are strong views around that, then please do respond to that consultation and let us know that. But legislative change does take time, probably at least a year, realistically. So to be aware, that's not going to be an instant sort of rule change because it's not as straightforward as that.
Thank you, Janet. And then we've got a question from Charlotte Mitchell around, which is probably similar, so you may feel you've, but anyway, it's can short breaks budgets be used to commission personalised care rather than to commission service delivery? My feeling was that would be within the gift of a local area, but Janet?
Yeah, I would say the same. Yeah, in terms of, converting it, as it were, to an individual package, that is definitely allowed. Yeah, but it would be for the local area to determine. Is that quite what you were getting at, Charlotte, or was it more with a kind of health?
Do you want to come in, Charlotte? We've probably got just enough time.
Yeah, thank you, Amanda and Janet. My question really is because CCGs are often criticised for not doing personalised commissioning for young people. Because all of our funding is generally tied up, but we do contribute to short breaks budget. So I just wanted to understand if personalised commissioning could be supported via that function, which it sounds like it could. So that's
yeah, absolutely. I think it could. I mean, the specifics of the arrangement will depend on how your contributions are managed locally, I think. So I don't want to say too much because I might not be accurate. But I think in principle, yes, it's definitely something that could be worked on together.
Fantastic, thank you.
And I know you had another question, Charlotte, but I felt that probably wasn't for Janet. It was about sort of waiting times. Do you want Lorraine to come back on that?
Yes, please, if possible.
I've just put something in the chat to say, read the waiting times. I'll take away the specific question, but my understanding is that we're waiting on the phase 4 letter and the planning guidance that's usually published before Christmas. I don't have a date on that, but I suspect there's going to be more information on what's happening to other services in terms of recovery, because in phase 3 the focus is around elective care and cancer and stuff. So leave it with me, I will come back.
Lovely, thank you.
And what we can do, Janet, we haven't got enough time sort of right now, but we can put your questions into a poll, which we can run at the end of the plenary session. So that might be a way of getting some more input to those in addition to people emailing. But I know sometimes, sort of once you've left a meeting, if you haven't done it there and then it doesn't always happen.
Yeah, that would be brilliant. Thanks, Amanda. That'd be great.
No worries. And I think I'm just looking to see whether there's anything else that's come up, because you've got a whole minute left, Janet.
Oh, wow. I can just see another question here about the role of DCOs. And to be honest, I think that's probably one for Lorraine and colleagues to look
I
at.
was thinking, since we've got Sue as well, so we'll leave that one for Sue and Lorraine. But we've also got, how is the DfE amending their work to ensure that education and care are part of the new integrated care approach across the country? From Darren. Hello, Darren.
Yeah, so I mean, this is obviously very, very live and very new. I think our first port of call, one of my colleagues said yesterday, we need a crash course on integrated care systems, and I think that's absolutely true. So what I would say, I wouldn't be able to say we've got specific things that we're saying we're going to change the way we do X, Y, or Z right now. We are very actively engaged with health colleagues around that programme. We have very regular meetings operationally with how we might align with that. And I think as that programme continues to develop and models emerge, we will be directly involved in contributing to those. But we don't have a kind of final roadmap of what that looks like at the moment.
That's super. Thank you, Janet. Thank you so much for that. And are you able to stay with us, Janet, or do you have to rush off to another meeting?
I'm okay for the next hour or so. I've got another meeting at 11:30. I'm
sorry, I didn't want to put you on the spot. I just thought if people have got other questions, if they carry on, if that occur to them, if they put them in the chat, just to ask if you can respond to them, just keep an eye on it. That would be super.
That's fine. And I've put my email address in the chat further up as well. And CDC colleagues have it. So if anybody desperately wants to get in touch directly, please drop me a line. And we will do our best to support that. Obviously, bearing in mind, I should have said at the beginning, it's a really small team that I manage. I don't want anyone to think I've got hundreds of people working on this programme. So yeah, it is a small team, and capacity is always a bit of a challenge, but we will do our best, and we will certainly try to pick up issues that people need to flag with us. So please do get in touch if that would be helpful.
That's super. Thank you so much, Janet. Right, well, I'm now really pleased to welcome Sue North, who's the head of the Children and Young People's Learning Disability and Autism team at NHS England, and David Lockwood, who is the Deputy Head for Perinatal and Children and Young People's Mental Health at NHS England, and improvement, of course. And I'm really glad to see that Darren is here and participates in the chat, because one of the reasons that Sue and David are here is because Darren said at the last event that that's what he'd like, and if Darren asks, then then that's what we do. So have I got you, David, Sue, and Kate? I'm sorry, Kate, I didn't actually look at your slides when you sent them over, so I didn't know that you were appearing as well.
So you've
certainly got me, Amanda. Yep. Morning.
Yes, and me. Thank you for the Christmas game.
Morning. Have you got some tinsel, Sue? Oh, you've got a
Christmas tree. I've got my penguin. We're all set.
Right. Well, with no further ado, I will hand over to you. Thank you very much.
Thanks, Amanda. I think I'm going first with this, just to fess up that Sue, Kay, and I were sort of trying to sort out over email who's going to do what in this presentation. So I'm sure it'll be absolutely seamless. But in case it's not, I've got my apology in first. I'm going to kick us off. So thanks very much for the introduction, Amanda. I won't say again who I am, but I think part of the request here was that following the session I think you had last time with my colleague Anne O'Hurley and Erica from DFE, which is around some of the mental health work in schools, there was a similar request for us to talk about the alignment between the programmes of mental health, particularly learning disability and autism, and SEND, etc. So that's what you get. Before we get into the details, quick starting point here. And one thing to land first off is as it says, the importance that all our programmes and NHS England as an organisation puts in co-production and working with parents, carers, families and children and people to make sure their voice is at the heart of everything we do. So it's in the Constitution, as you can see there, it's part of our public commitment. But I think it's also, speaking for Sue and Kate, but I think I'm on safe ground, it's been part of our sort of real ethos within our programmes for ever since we've been doing this, and we've been doing it for some time now. So, but I think that's the first thing to hold in mind, is how important that is to us. Next slide, please. I'm sure it's coming. The next one will be a bit of policy context. I think you may have seen the policy context from, there you go, last time around when Anne was here, but I think it's worth just mentioning it again. From my perspective, in terms of the mental health programme at NHS England, I think we can trace our roots for the current effort that we're in at the moment back to Future in Mind back in 2015, even though there was work before then. But you can see that the continuation that we've had from Future in Mind into the 5-year forward for mental health, and then more recently into the Green Paper that I've been particularly involved with. Within that, there's one of the real key themes and ethos that we've been trying to deliver in that transformation is not only increasing the amount of support there is, increasing access to help, but also changing the way it's delivered. So moving away from a feeling that mental health services are organised by the boundaries of what they're commissioned to do or what a particular diagnosis is, but around what is the need of the child or the young person and their family. And alongside that, a really core theme running through this and relevant to this conversation is that the huge overlap that you have around mental health need and needs that will arise from children and people who are neurodiverse or have other issues. So that's right from the very start has been kind of core to our ethos that we work very closely with, even though we're separate teams with Sue and Kay and with Lorraine, but fundamentally the vast majority of these they're all the same children, same families that we're trying to support. So again, hold that in mind. Next slide, Marie. Which I think might be you, Sue.
It is me. So I'm just going to talk a little bit about kind of our policy foundations around learning disability and autism. I think the slide will come up shortly. So for the learning disability and autism programme, some of you will be familiar with some of the underpinning policy documents around valuing people now, Winterbourne View, and for us, building the right support was our framework for commissioners around developing community services for people with learning disability, with autism or with both, and behaviours that challenge a mental health condition. And it was the response really to Winterbourne View and those abuses that people in mental health hospitals with a learning disability or autism had experienced, and about the fact that we know that for some of that population that they were often inappropriately being admitted, having really long lengths of stay, and that it was often a response about the lack of community provision to support them. So building the right supports kind of our policy framework. Aligned to that was the care and treatment policy, which was around the importance of those multidisciplinary person-centred reviews that should happen before somebody was admitted to hospital to see if there was any way their care and treatment could be delivered in the community. But I think it would be fair to say that policy document was quite an adult-focused document, so we were able to support that with the policy that you see right at the front, which was the supplement for children and young people to building the right support, which is called in its succinct title, Developing Support and Services for Children and Young People with Learning Disability, Autism or Both. So that translated the principles of building the right support for children and children's commissioners. We know that there are some differences in terms of children and adults and the commissioning landscape and the framework, but the ambitions were absolutely the same about making sure that children and young people were not being admitted to mental health hospitals unless there was an absolute clinical need and there would be some therapeutic benefit of that admission. Around avoiding unnecessary admissions, about developing community provision and support for that group of children and young people. And so originally we were part of that whole Transforming Care programme. However, the NHS long-term plan really helped to confirm and prioritise the need for the continued approach for children, young people and adults with a learning disability and autism. So alongside mental health, it identified learning disability and autism as a strategic priority for NHS England. Really clear commitments about children and young people having a better start in life, around addressing issues regarding inequalities and health inequalities, as well as continuing those commitments around reducing mental health inpatients for children and young people, developing and strengthening community support, and then some specific commitments around key workers and sensory checks for children and people around eyesight, hearing and dental checks, and also a commitment around testing approaches to autism diagnosis, recognising the significant issues and challenges there are around that at the moment. Thank you. If we could move on to the next slide. So we just wanted to share with you, I think, some of our governance structures, because as David said, we work very closely in the mental health programme and the learning disability and autism programme, and we have a range of, we have our own governance structures which help underpin and structure our work, but then we also have some collective governance structures as well. So there's the Children and Young People's Mental Health Programme Board, we have the Learning Disability and Autism Programme Board, we have our steering group, and Janet was talking earlier about the cross-system working group that sits underneath our Learning Disability and Autism steering group. And then collectively in NHS England, we have a Children and Young People's Transformation Board, which brings together all of the programmes for children and young people across NHS England. And then there's the Mental Health Dementia Programme Board and the Green Paper Programme Board. So lots of different governance structures. But, you know, I think there was a clear recognition in the long-term plan that often work for children may be a bit disparate across our organisation. Some of that was about timing or where work had started and where it was driven from. So it was really important to bring that together. And I guess the other really important governance structure that helps underpin and bring our work together is the CAMS Clinical Reference Group. The group itself meets quarterly and it's chaired by the 2 national clinical directors for Children and People's Mental Health Services. So that's Pratibha Chitsabeesan and Tina Irani. And then you can see there the working groups that fall out of the CRG. One of those is specifically around learning disability and autism. And then you can see the others there. Provider collaboratives, you know, a new landscape for us. Restricted practice, again, a significant issue for us across mental health, learning disability and specialised commissioning, complex eating disorder, as ever, workforce and data underpin all of our work. So just to kind of give that overview really of how some of our governance works. And back to you, David.
Thank you, Sue. The next couple of slides are just intended to give a flavour of some of the progress and kind of status of how far we've got. So this one, again, you might be slightly familiar with this if you remember Anna O'Hurley's presentation in October, but worth showing again because there's some good news on here from my point of view. These are the kind of programmes within mental health that have been delivered, but as it says at the top there, because of that overlap, these will be also benefiting children and people who have other issues, including where their neurodiversity is there. So headlines: increased spend across children and young people's mental health since the start of the programme and the 5-year forward view. There's been a big increase in workforce. I'll say more about that in a second, and big increases in the size and scale of a lot of the services out there. So that's within the community. That includes the new school-based teams that are from the Green Paper, within inpatient, and within areas such as health and justice and mental health. Right at the bottom there, I think these are the sort of key points of this slide in terms of that progress. We've seen quite a significant increase in the number of young people who are actually accessing services. So we had a commitment for the 5-year forward view, a target that many of you will remember, that was to move from 25% access to 35% access. We actually met that a year early, which is great in one sense. So it shows that transformation is possible. However, 35% is still nowhere near good enough in terms of the needs of children and young people. So whilst we don't rest on our laurels on that, we take that as a good positive step, but shows there is a lot more still to do. Next slide, please, Marie. I mentioned workforce. In visual form here, you can just see some of that upscaling workforce. So this is particularly the community workforce for mental health, but you've seen a similar picture in other areas and also in the voluntary sector. But there you can see that the increase in whole-time equivalent, I think the numbers behind that is something like 7,000 whole-time equivalent staff in, I think, 2016 when there was an audit, up to around 11,000 now. So again, a big expansion. However, if we go to the next slide, there's always a but with these things. We've seen the demand on services increasing as well, either at least keeping pace, if not starting to outstrip in some areas. So what we've got here are the bar charts are annual referral rates for children and people's mental health up to 1920. You can see the shape of the curve. If you click next, please, for Marie. Yeah, so this is slightly different. This is monthly totals, but this is during the main parts since the pandemic started. So you can see there, again, that same sort of shape of increase, but also some of the numbers there very high in terms of referrals. So that's starting to manifest itself, I think, in the increased demand that we are now starting to hear reported from services. Not only from the underlying prevalence of mental health issues in society, but also how they're starting to be exacerbated by COVID and the things of the pandemic. And we'll say more about that shortly. But I think, Sue, I think I might go back to you next.
Yeah.
So I think it might be me, Sue, if that's okay. The third member of this tag team.
Okay.
Slide. That's okay. As you can see, we've rehearsed this a great deal, and it's absolutely seamless. So in terms of the data, this slide shows you the changes that we've seen in the numbers of children and people who have autism or learning disabilities who are in mental health settings over time from the March last year, and also specifically through the pandemic. And the green line and the red line show the long-term plan commitment to aim towards the reduction of young people in hospital under 18 to between 12 and 15 per million. So through the pandemic, we've seen a continued and sharper reduction, although in the same period of time, we can see that the percentage of children and people who have autism is increasing, and particularly those young people with autism who are female. And we know that reporting is improving, so that all those young people who have autism are being identified wherever they are in terms of mental health hospitals, eating disorders or otherwise. And we're also aware that there continues to be quite a large number of children and people who actually receive a diagnosis while they're in hospital. Marie, if you could go to the next slide, please. So the decline that we've seen in inpatient numbers is helpful in moving us towards our target, but it is obviously something that we've noticed increasing as part of the pandemic. And we'll be talking a little bit more later about what we're aware of in terms of admission avoidance and young people coming through for crisis but not actually being admitted. This slide gives you a little bit more detail around the way that the group of children and people that fall within transforming care has changed over time. And so there has been a substantial reduction in children and people with learning disabilities. That is 86% since March 17. Whereas over the same period of time, we've seen a marginal 10% increase in children and people with autism. Partly, as I say, due to reporting rates, but partly also because we're better understanding that group. And I think the increase is mainly accounted by young people in terms of girls. I think what's also interesting is that those in hospital in the 18 to 25 group, not illustrated here, there's a slight shift in that children and people with autism are a smaller percentage, and of those with autism, only 40% are girls, whereas in the under 18 group, 76% are girls. And so obviously this is something that we're tracking closely and better understanding. Next slide, please, Marie. So the next slide goes on to talk about key working, which is one of the long-term plan commitments that Sue referenced earlier. And I'm mindful that some of you on the call today are actually well involved in key working and will probably be involved in some of the top pilots I'll go on to reference in a second, but I'm making no apologies for sort of drawing attention to this again, as this is one of the significant pieces of work with funding attached that we're rolling out at the moment, and obviously is implementing a recommendation that Christine Lenahan made back in her report, These Are Our Children. And whilst over the duration of the long-term plan, this will be broadened out, in the first instance it's targeting very much young people who are in mental health settings, or those who have been identified as being at risk of going into mental health settings through the dynamic risk registers that each area has across the system. Marie, if you could move to the next slide for me, please. So developing the key work commitments in the long-term plan, started with a blank piece of paper and worked through consultation and co-production, and colleagues at the Council for Disabled Children, Amanda and Dan, were commissioned by Health Education England to scope the existing work that was around key workers or emerging roles that kind of fulfilled some of what key working could be, to sort of consider what worked, what the challenges were, and how a new offer might work. And building on this consultation and the co-production that we did through multiple meetings, the CDC produced for us some guidance on what key workers should do, described as the key working functions and the competencies that people in a key working role needed to have to test during the pilot phase. And if we move to the next slide, you'll be able to see where we're at currently in 2021, which is that we now have 13 pilot sites who are mobilising across all regions of the country. They are at varying stages at the moment in terms of their mobilisation. We have one site that is amazingly operational at the moment in terms of they have people in post, and they are beginning to start their induction and take up young people. We have other areas that are hoping to be operational from January, and other areas that are just continuing to work through some challenges around recruitment, which I think we would probably all understand currently in relation to the pandemic. So all areas have got cross-system sign-up. That was one of the requirements of being a pilot. So we recognise that key working isn't something that's just about a health initiative. It's around working across education and social care, as Sue's just put in the chat. And we're working closely with our colleagues from the National Network of Parent Carer Forums to really ensure that co-production and participation and engagement on a strategic level with parents, families and young children, and at an individual level with parents, children and young people is central to key working. So while we're mobilising, or our pilot sites are mobilising across these areas, we are in the process of looking for our early adopter sites. The financial modelling has been agreed, and we will be looking to further areas to submit expressions of interest in the new year to join potentially 14 early adopter sites to carry on the sort of testing and the refining of the model for 22-23, which will be where we're looking at full geographical coverage. Next slide, please, Marie. So I just wanted to make brief mention of an additional output from the consultation around key working, which identified for a small group of children and young people who are in hospital, an additional role would be required, and we are piloting working with a small number of consultants operating in a semi-independent role to act as senior children's interveners, to work with a small number of children and people who are in hospital, who have significant complexity, which creates substantial challenge in systems, community systems, meeting their needs in the community, which can lead to delays in their discharge and extensive hospital stays, and sometimes associated with restrictive practice such as remaining in seclusion. So we're working alongside our regional colleagues who are identifying and escalating these children and people, and we're sort of focusing on a sort of a national perspective, identifying them where they have perhaps a concerning length of stay, and working with these three consultants who come from senior sort of background level director roles across the system, who are working to provide additional capacity, expertise and support and challenge at a high level of seniority across the system to look at the barriers and blockers are to supporting these young people coming out of hospital. And so we're capturing feedback and trying to understand the emerging themes and issues that they're highlighting. There is a growing interest in their work, and we are piloting this until the end of March next year, and we'll be considering how we take it further forward with evaluation sort of informing and underpinning the expansion that we're able to do. Senior Children's Interveners is a somewhat controversial name, but we're going with it at the moment because nobody has really been able to come up with an alternative for us. So we're not expecting that these roles will be something that you'll necessarily hear much about or come across, because they are for a small group of children and people. But just to reference that the community key workers in the pilots will also have a role for those young people who are in hospital in supporting their effective outward journey from hospital and successful implementation of community support. And I think I'm passing on to Sue now for the next slide, Marie. Thank you.
Thank you, Kate. Sorry, I've just been typing away to some of the answers, but we're happy to talk more later as well. So I guess the other thing that we just wanted to update on, which again is a programme of work that sits across mental health, learning disability, autism and specialised commissioning, is the Quality Task Force, which some of you may be aware of. So this is a task force that was created. It's chaired by Anne Longfield, the Children's Commissioner. And it was the result of a range of serious incident reviews and the CQC thematic reviews around the use of restrictive practice, long-term segregation and seclusion for children, young people and adults in inpatient mental health services. So some of you will be familiar with some of the maybe the high-profile cases that there have been over the last few years, and with the fairly damning reports from CQC about this, and we know that there are a small group of children and young people in inpatient mental health settings who find themselves being cared for in that really restrictive way, which can often be quite traumatic and often exacerbate some of the challenges that there are. So the Quality Task Force has an ambition about improving the quality of inpatient provision for this group of children and young people. There are 5 areas of ambition. One is around people, the workforce, making sure that people have the right skills and capacity to be able to manage and care for children and young people with some of those complexities around their needs. Around care management, how we can make sure we're really improving the care management of those children and young people when they're admitted to inpatient settings. Around quality assurance, there's a whole range of quality assurance that should be in place already. Some of it has not always proved to be very effective. So how we can really strengthen that quality assurance overall in relation to that. And the environment, we know particularly for young people with autism and for some of our children, young people with a learning disability or other sensory difficulties, the physical environment of being in an inpatient setting, particularly if it's a secure setting, is often really an additional exacerbation that creates additional difficulties for them. So there's a significant piece of work going on looking around the environment, including technology. And then very specifically work around the use of restrictive practices in inpatient settings, and a real commitment in terms of the reduction of the use of those restrictive practices, and ensuring that when they are being used, that they're being reviewed, that there is stronger support for children, young people and families in terms of understanding the impact of the use of some of those restrictive approaches to their care. So the Quality Task Force paused for a short while during COVID, but it is back up and running at full speed again, looking at those elements in terms of our long-term vision for those inpatient mental health services. But again, aligns entirely with our ambition for children and young people with a learning disability and autism, around reducing admissions, because we know for many of our children and young people, it's often not the right place for them to have their care and treatment needs met. David, over to you.
Yep. Thank you, Sue. The next few slides are just summarising some of the feedback we're starting to hear from our colleagues out in services. And I think I saw a comment from Darren that may earlier on that may have kind of sort of foreshadowed some of this. But the impact that we're actually seeing on children and young people. From the mental health clinical networks, one of the points that we've been hearing is that for some CYP, the actual pandemic, they've broadly been okay managing through it if they've had the right support. So that includes from services and from their families. But there are also a significant proportion that have found it particularly challenging and have faced a deterioration in things like that, either an existing condition that they may be seeking support with, or have presented with a new issue. And I think, Darren, this was your point about the increasing acuity that's coming through in services. Some of the risk factors on there and causes, I'm sure none of these will be of any surprise to any of you, but kind of worth reflecting on this around, it's the loss or bereavement from the actual during the actual pandemic itself, the loss of structures. So one of the big sort of reinforcing structures for a lot of children and young people is obviously their social life, their school life, and their families. All those being gone during pandemic has actually wrapped up the anxiety and led to further issues, and also the significant numbers of people who are now living in home environments that are less than ideal. So with things like parental conflict, which is now manifesting itself already in that increasing need that's coming through. As it says at the bottom of the slides, the children and young people who are neurodiverse are particularly at risk. Are one of the groups in here that are particularly at risk of these factors. Sue, I think you're taking the next slide, which is a little bit more specific around the group. I think it was you rather than Kate that we decided on.
Yes, that's fine. Thank you. So again, just kind of reflecting on what David was saying. If we can move on to the next slide. Again, we've heard from children, young people and their families about some of the increased challenges that they've experienced during COVID and during the restrictions that were brought in because of COVID. I think kind of Kate mentioned it earlier, we initially at the start of COVID saw a decrease in admissions, but we did see a surge and we were really concerned about that. I think not unexpected in terms of us knowing that lots of children and people were not in school, that there was significant increased caring responsibilities on families, and some of the restrictions particularly adversely impacted those with autism or with a learning disability. I think again we mentioned earlier we did some additional specific work around admission avoidance for this group of children and young people kind of September, October, November time to really try and reflect and support that, because not only do we have the challenge for those young people and their families and their presentation, but we also know that our provider settings were also challenged in terms of staffing. I talked a little bit earlier about some of the concerns and challenges around the use of restricted practice in some of those settings, and lots of the quality assurance processes have had to be amended and reviewed and are virtual rather than face to face. So we were really keen to try to make sure that again families and children and people were being supported in the community wherever possible. But we know that it's been a really difficult time, a really difficult time for children, for young people, for families, for services in trying to respond to that effectively, as well as responding to the pandemic. If we could move on to the next slide, please. I guess we just wanted to share with you some of the research that some of our colleagues from Autistica and the National Autistic Society did specifically around the impact for autistic children and young people. So you can see that there was kind of a higher risk around anxiety, trauma and other mental health difficulties during this period. Again, an increased likelihood of loneliness, and we saw through the work that the National Autistic Society did that 2 in 5 parents, carers didn't feel that they were able to support their child's educational needs and that their academic progress was suffering. So we know it's been a tough year all round. So I think we we are mindful of that. We know that we're likely to still see the impact of that for months to come. But we did want to, I think, kind of just help demonstrate. I think, you know, when we were first asked to come and speak, we were asked to come and talk about the crossover between our programmes and some of the work that we do. So we've tried to share with you, I guess, what our priorities are. We've shared a little bit about how we work together, and we're just going to talk now about some of the very specific ways in which our programmes have worked together and are working together. So, Kate.
Thanks, Sue. Marie, could we move on to the next slide, please? So Sue's highlighted that this crossover area is one that we're focusing on, and for us it's really significant because of what we know around the mental health needs of young people with autism in particularly. And Sue's outlined some of the challenges that has been faced by families and young people with autism as a result of the pandemic, and recognise in the chat that it's also been mentioned that for some of these young people, actually being able to be at home and not being in school has perhaps alleviated some of their challenges that they experience, but then the return to school and the coming out of lockdown we noticed also associated with an increase in young people going into crisis. So change really is obviously significantly associated with autism, and autism isn't a mental health condition in its own right, but we know that there is a strong association with autism and anxiety, for example, and that these are co-occurring independently experienced mental health needs that can be addressed and treated in their own right, albeit requiring significant, in some cases, adjustments, and acknowledging challenges in sometimes identifying the way that these anxiety disorders present, particularly in relation to autism, and the challenges in the response that is experienced as a result of the anxiety and how it impacts on families and young people. Next slide, Marie, please. So as well as recognising that children with autism in particular are at high risk of anxiety, we are also aware of the association between disordered eating and particularly avoidant and restrictive food intake disorder. I'll go on in a moment to talk about the work of the CYP mental health programme in addressing this that highlighted the need for us to think about this in more detail. But ARFID is recognised as one of the group of eating disorders. There is growing recognition of the risk associated with autism and disordered eating, and also an eating disorder. And ARFID can present in children with autism in terms of creating exceptional challenges for their families and also for schools around the kind of the restricted nature of diets, the rigidity associated with meal times, and conversely can also be associated with significant weight gain. So it's obviously got sort of other child health concerns and considerations, and it's an area of study that obviously is something that is gaining interest, and we're learning through research. If we could go to the next slide, this feeds in nicely to work that has been undertaken with the CYP mental health programme in recognising wider issues around ARFID, not just for children with autism or learning disabilities, such that from September to August, a pilot site per region based in one of the CYP community eating disorder services participated in a pilot to sort of learn more about the adjustments that could be made in community eating disorder services to ensure access to the right support for those with ARFID, including those who have autism. And those pilot sites have been sort of testing those adjustments, looking at the training requirements of staff, data collection, and sort of feeding into a national evaluation. And There is now a process of sharing that information across other eating disorder services that's taking place presently, and to look at how to improve access as business as usual in delivering community eating disorder support. And obviously there'll be a process of exploring how extra resources through the long-term plan can, over the course of the next few years, look at how all children with an eating disorder experience improved, access to treatment. As part of being alerted through the evaluation of the percentage of children and people who were presenting with autism in the pilot areas, we were able to commission Autistica to produce an ARFID and autistic people briefing paper, which was based on a systematic review of the research literature and involved Rachel Bryant-Waugh, who was the sort of lead clinician in the ARFID pilots generally, which enabled 2 webinars to be delivered, raising awareness specifically for staff from the Eating Disorders Charity Helpline Beat, and another for commissioners, clinicians and providers that you may well be aware of if some of you were able to attend. And if people are interested in having a look at that briefing paper, I'm happy to forward it with the minutes of the meeting. Next slide, Marie, if that's okay. Thank you. So the next slide is a challenging slide because it refers specifically to suicide, and obviously it's important to point out that suicides in children and people are mercifully rare, but through looking particularly around the time of the pandemic at the rate of suicide in children and people, it became apparent that children and people with autism are overrepresented in that group. And more research is required really to better understand that group, and we are aware of studies that are going to be reporting shortly that will further understanding. In response, you'll be aware that the 24/7 all-age mental health crisis helplines were implemented ahead of initially expected as a result of the pandemic, and there's been clear messaging from the National Clinical Director and other initiatives that will be mentioned shortly. Just sort of completing these slides in terms of the challenges particularly posed to children and people with autism around mental health is for all children with the social challenges that they may experience in their life can contribute to exacerbating mental health conditions, but we're particularly aware of this in relation to children who are autistic and who have learning disabilities, in that they are more likely to be not in school, either through being suspended or through being expelled, or we've noted an increase in elective home education because of the challenges of social inclusion and the experience of bullying, and those likely to contribute in different ways to exacerbate mental health conditions. And I think I'm handing over to David for the next slide.
Yep. Thank you, Kay. I'm aware of time. I think we're actually over, so before anticipating the hurry up from Amanda. So I think some of these we can go through.
What I was going to say, David, is
Yep.
I can see from the chat that people are really valuing the input. So
Okay.
I've taken the executive decision to eat into a bit of the break time, but I would like a couple of be able to present a couple of questions to you. So if there's any way you can speed slightly, that would be fab.
Will do. Well, this next one I can go through pretty quickly because I think it's a point that Janet made in her presentation earlier that I think we would entirely endorse, but that's about the importance of the response to these needs being whole system. It's not just about the teams that Kate and Sue and I work in doing this in NHS England, but it's about whole support, it's about the prevention agenda and support for families. But I think everybody will know where I'm coming from that. So I suggest we jump over, I think it's 2 slides, Marie, to get to the actual text. It's just a few examples of specific things that have happened between our 2 programs that have kind of built some of the improved response, or we hope improved response for children and people in these groups. So I think we already mentioned earlier on about the provider collaboratives work, about that are looking to kind of refresh and improve the way that some of the most specialist and complex service delivery happens, and that includes focus on inpatient children, people's mental health care, and autism and learning disability children and people's services. We've mentioned the task force, I won't repeat that. There's a number of task and finish groups that we've had that run jointly across the programmes. I think again this Matt got mentioned early on about the improving access to assessment and diagnosis around autism, and also a kind of proactive piece of work looking at avoiding admission to inpatient in anticipation of a surge. And that last point there about Autistica, I think we've just covered that in the point that Kate made in the previous thing around the crisis lines. So if you want to go to the next one, Marie. And in some ways, this is kind of, we're ending on a little bit of a kind of a techie thing, but on the next slide, we've just got some examples of how we've built this kind of, the thing I mentioned right at the very start of the presentation about the need to think of the overlap and the co-occurring need basically between, it's not, they're not distinct groups of individuals and families where there is mental health over here and, neurodiverse over there. So some examples, many of you will be familiar with things like the local transformation plans for children and people's mental health that came out of Future in Mind. They've, right from the very start, have had within them in the guidance to local areas to say that you need to be thinking about needs, including learning disability, autism, disabilities, etc. as part of that. And it's part of the review that happens regionally in the NHS each year to assess, like, have the plans been republished. Within NHS England, we have invested in our clinical networks and put extra expertise and advice in there to guide services. That's included through this something we call the mental health improvement teams, specific focus within that on need, thinking through the needs around these particular children and people and their families where there are co-occurring issues. Autism learning disability is part of core training in the Children and People's Improving Access to Psychological Therapies Programme, CPAT, and also as part of the new school teams that have been rolled out. It's within the module there. I mentioned the 4-week waiting time pilots that people may be familiar with, just because that work is continuing. It's about how we can speed up access to NHS mental health services. But within that, one of the key things that's come forward is how best do you meet the needs where there is of children and people, where there is, it could be complex and co-occurring needs, and particularly where there are things like autism and learning disability, where traditionally you will see an assessment period that can take much longer than, say, a 4-week window. So that's live. That will be part of the advice that will be going up to government soon, but that's very much to the forefront. The last point is just about to give people a heads up. There's been a range of resources that have been prepared around helping commissioners and providers really tailor their services and make sure their pathways are as appropriate as they can be for children and people's mental health, that within that have got that consideration around neurodiverse issues. Expecting those to go live sometime in the early new year. I'm very happy, Amanda, to share with CDC and others as that happens. I think the next one is our last slide of substance. I don't propose to read through it all given time. It's a summary of everything, the key ambitions within the long-term plan that should all stack up to delivering much better outcomes for the children and people and their families we've just been talking about. So it might be, Amanda, at that point, we could maybe leave that slide up, maybe move to the questions. We had a question in there about feedback on how planning and local alignment is going on planning. Might not be time to do that, but it could be that your colleagues could give us that feedback after this session if you like. But if that's a good point for us to maybe pause and take questions, I'm happy to do so.
That's super, and thank you all so much, the three of you. That's been I know you overran, but you got through so much. There was no waffle in there. Thank you very much indeed. There are some questions which I know have already been answered in the chat. I thought we should, since Darren asked for you, I thought we should actually let him ask a question, and he had two. So Darren, did you want to come in?
I think both my questions have been answered within the chat.
That's marvellous.
But I asked for this, but it would be nice, and it's just me, and SEND and LP and everything else is all about, how we work together across education, health and care. We've had a presentation from education from somebody DFE, somebody from health. It would be nice if we had a presentation showing how everybody works together, how all this is jointly formulated, how it all works, because we get separate presentations, but on the ground, we're battling with that joint working, and with the new integrated care stuff coming forward, the battle's only going to get harder. Sorry, just my own personal opinion.
The Grinch has got you, Darren.
I'm happy to respond. I won't say a good answer because I'm not sure I can answer. But Darren, I just think that that's such a helpful point, because the reality is we can't deliver for our children, young people, unless we have that integrated approach in all of our work, you know, on a national, regional and a local level. So, I mean, I think you're right that, you know, we have kind of presented in different ways, but I think it would be fair to say, particularly of those of us here today, kind of Janet, Lorraine, myself, David, we work, and all of our work is really closely interlinked, and I think probably in a way that is much stronger than it has ever been. You know, we are clearly from different departments and arm's length bodies, you know, and you know, we can't get away from that, but I think we're trying to integrate as much as we can within that, in the same way that, you know, we're asking our regions and our you know, local areas to do. So I think that's a helpful challenge though, and maybe in the future we need to think about how we can jointly perhaps deliver our programmes of work and our plans.
Thanks, Sue. That's really helpful. And I think we've got two other comments that kind of feel quite allied. So Juliet Ridgway was asking whether we're confident that diagnosis of LD is being captured and recorded effectively. Sorry, Juliet, I think I might have got that question. Was it autism, was it LD, or was it both?
Learning disabilities. So it's about there was a slide saying the number of people with ASD had gone up, but the number of people with learning disability had gone down. And I'm not confident in our area that we're necessarily capturing a diagnosis of learning disability as a separate record.
And Juliet, does this speak to the issue that's been running on the DMO
Yeah,
DCO forum? Yes.
Yeah.
So childhood diagnosis of global developmental delay, they're not necessarily getting transferred into an adult LD diagnosis. So yes. we try and follow that up, didn't we, Sue?
Yeah, so I think just to clarify, the data we showed was around inpatient admissions into mental health settings. So what that data was showing was that fewer children and young people with a learning disability without autism are now being admitted into mental health inpatient settings, which we are pleased about, because for most of those children and young people with a learning disability, their care treatment should be provided for them in the community. So just to be clear, the data was around inpatient admissions, but I think that's a really helpful point, and I'll be really happy to take that back. And Julie, perhaps we can pick it up offline and feed it back into our CAM CRG if we think there's an issue becoming more apparent.
Thanks, Sue. And then finally, and this isn't a quick one, so it might be just a question of saying to Dhrendra that we'll kind of think about it and get back to her, but just a concern about the fact that because the programme focuses on LD and autism rather than neurodisability more generally, is that, you know, she has a concern that it misses out some other conditions, including some mental health conditions like bipolar, and does it mean that there's a kind of a rush for an autism diagnosis, if you like?
Yeah, I think we might need to come back and I mean, really interesting kind of point, and clearly an issue of much debate, I think. So again, we're happy to pick that up offline. Okay, super. Well, thank you all very much again. David and Kate, do you want to switch your cameras back on so that you can receive the warmth and approbation of your colleagues for a really really full presentation. Thank you so much. We don't generally do clapping virtually, do you? But feel clapped.
Thank you. Pleasure to be here.
Thank you for having us.
Thank you so much. And I'm going to move on to Nick Whitaker without further delay. And sorry, Nick, because I didn't even consult with you about eating into your time. But we have got a break, which I'm going to eat into so that you still get your half an hour. And I did put some fat into the agenda. You may have thought you were getting breaks, people, because it's nearly Christmas, but apparently not. So we'll try and make sure there is at least 2 short comfort breaks, but I made them longer than because I thought we might end up shaving them. So Nick, I have seen you come in, but I can't see you yet.
Hi, Amanda. Can you hear me?
Marvellous, marvellous.
Excellent.
Welcome very much, Nick Whitaker from Ofsted, who is going to give us a bit of an update on how things are looking on SEND. Thank you very much, Nick.
That's great. Amanda, I'm just checking that that everyone can see my
Well,
slide.
I can see them, Nick, so I'm happy.
That's cool. I'll switch off my camera, I think, so that it works better. Okay. Thanks, Amanda. Hello, everyone. My name is Nick Whitaker. I'm one of Her Majesty's inspectors, and I'm Ofsted Specialist Adviser for SEND. And I've seen on the chat that Yvette's here as well, who you know from Ofsted. I'm really pleased to be here today to speak to you about our work with the Care Quality Commission. And in the time that I've got in my half an hour, I'd like to talk about 3 things: our work in the interim period, so this period of time when routine inspection is paused, and in particular what we've been learning from our visits to local areas, our thoughts about restarting area SEND inspections, and I'd like to say something about the future of area SEND inspection as well. A lot of what I'm going to say in this session is summarised in the commentary that Her Majesty's Chief Inspector Amanda Spielman published in July, and you may have heard Amanda and other colleagues in Ofsted and CQC talking about some of these things last week when we launched Amanda's 4th annual report. But my starting point, I think, is to remind you that our inspections have 2 main purposes. We provide an independent external evaluation of how well an area is fulfilling its duties in relation to children and young people with SEND. And in doing that, we are aiming both to hold areas to account and to assist areas in improving and developing the local SEND system, and getting it right is about balancing those things well. Just looking back over the period that we've been inspecting area SEND, you'll know that we've inspected 117 local areas since May 2016. About half the areas we've inspected have been required to submit a written statement of action as a result of significant weaknesses that inspectors have identified, and I'm sure you'll agree that proportion is much too high. We've revisited 21 of those areas to assess the progress that's been made in tackling those weaknesses, and looking across those 21 revisits, about 2/3 of the weaknesses that had previously been identified have been addressed successfully. But that does mean, of course, that about 1/3 of those important areas for development haven't been tackled sufficiently well in that period of time between the main inspection and the revisit, and that's usually about 2 years. And that's why that first bullet point is on that slide, because I think what that tells us is, despite the expertise and commitment of those working in SEND in England, there are many problems which we see which are long-standing and systemic. Just to give you a bit more detail on those things, about almost all of those 21 areas needed to address some weaknesses in strategic leadership. All but one were successful in doing that, and many of those areas had come from a very low starting point, where weaknesses in the leadership of the area's SEND arrangements. Where there'd been positive change, the team that revisited the area could see that there'd been a change in culture, and there was greater ambition. The most successful areas had tackled quite entrenched attitudes, had created much clearer lines of accountability, partnership working had been strengthened. And we recognised that in some of those areas, not least because of the starting points, that work had taken considerable time, but absolutely was heading in the right direction. And I don't think it's a surprise to any of us, is it, that we found there to be a strong correlation between the strength of leadership and an area's success in addressing any other weaknesses that had been identified. Again, where areas had made most progress, they'd been successful in addressing problems in their approach to working with families. The role of the Parent and Carer Forum had featured prominently in those very successful areas. And parents and carers told us that they'd been meaningfully involved in planning and decision making at individual and strategic levels, and leaders had given real weight to their views and experiences. Where practice was strongest, leaders had recognised that effective co-production means working with families as equal partners. And the same, we could also see that in some areas there was significant work still to do, and where that work had been less successful, even when there had been an ambition to work collaboratively, there had been the involvement of parents in co-production had either faltered, or on occasion it had been tokenistic. More generally, areas have been less successful in tackling weaknesses in joint commissioning, where that work had been, that really important work had been held back. We could see that an important factor had been the extent to which leaders had an accurate, detailed, rich view of the needs of children, young people with SEND and their families, and that was hampering their ability to commission the right services in the right way. We've seen across those revisits that the quality of education, health and care plans has remained a concern. We've looked at the quality and the integration of advice from different education, health and care professionals, and we continue to see some variability in that. And again, in areas that had made a strongest process with not just improving the quality of plans, but improving children, young people and families' experience, they'd got really strong systems for checking draft and finalised plans and for getting feedback from parents, carers, other professionals about their experience of statutory assessment. I'm sure you've seen and we've seen a growing concern about the timeliness of annual reviews and the quality of annual reviews, and of course the impact of that is that children, young people's new or emerging needs are not identified or assessed or met effectively, and parents are angry and frustrated about why the plan that their child has doesn't result in a better experience and more positive outcomes. So those three bullet points in the next part of the slide, I think, summarise our main concerns, our continued concerns about how the SEND system is working, flaws and inconsistencies, delays in identification of children and young people's needs, and we see both over and under identification in the SEND system at the same time. So some children and young people's needs not being identified in a timely and an accurate way, but at the same time, other children and young people being identified as needing something additional or different, when in fact their needs arise from a weakness or an inconsistency in the quality of a universal service, such as the quality of education they're accessing in school. And the second point on there about which builds on that, really, doesn't it, about too little system-wide focus on the importance of providing high quality universal education, health and care services. So the things that we know, when they are done really well, prevent children, young people's needs and difficulties from escalating. And finally on there, a lack of clarity about who's responsible for what, and the kind of fractures that creates in the way that different professionals work together. And so we know, don't we, and you know, we've spoken about this in our annual report, that the impact of those things can be area arrangements feeling like they are a battle for families as they're being too slow, and families being dissatisfied with their experience, and the quality of the services and support they receive failing to live up to what was envisaged, what they hoped for, as a result of the work that others have done. And of course, it would be wrong, wouldn't it, to continue without recognising that, as others have said already today, that children, young people with special needs or disabilities have been impacted significantly by the coronavirus pandemic, and that has created some new problems, hasn't it? But there is also an argument that the disruption that the pandemic has caused has added to the difficulties that children, young people with SEND have experienced over a longer period of time, and further exposed the weaknesses that pre-existed the pandemic in local SEND systems. So moving on. So what I'd really like to do now is say a few things about our work in this interim period. So in the period of time when routine inspections have been paused. We have, in October, we visited 6 local areas as part of our programme of interim visits. We plan to visit more areas in a second and third round of visits in the spring. Our priority in this time has been to work collaboratively with local partnerships to do the things on that slide, to understand children, young people's experience, to give voice to that, to learn from what's worked well and from what hasn't worked well for them, to support local areas in prioritising and meeting the needs of children, young people with SEND when there are significant and often competing priorities in the local education, health and care system, and importantly to promote learning for all local areas, for our partners in government and all of our stakeholders through a series of national reports. We published the first report from these visits on the 10th of November. We will be publishing a second report in December next week, and we plan to publish a final report based on the learning from the whole programme of visits in the spring. So the visits are collaborative, they're inquiry based, they do aim to give us some insights into how well the system is working, but also to help us to see the point at which areas will be ready for us to restart full inspections. We're aiming to use what the expertise of our inspectors to help areas get to that point in a strategic, in a supportive and a evidence-based way. We've been clear to explain that these visits aren't inspections, neither are they a substitute for our current area SEND inspections. We don't make any judgments through these visits or publish any reports about individual local areas. So a few things that have a few insights from these visits, the things that have and will feature in our national reports. Like other important research and surveys, we've seen that children and young people with SEND and their families have struggled during the pandemic, and the withdrawal of essential services alongside the loss of informal kinds of support from friends and family has left some children, young people, families feeling isolated, some abandoned. We've learned that families have told us that they've found it more difficult as time has gone on in this period. We've seen that poverty has become a bigger issue for more families during this period. School leaders have told us that some children, young people are experiencing greater levels of anxiety, which have required additional specialist support. Providers have told us, some providers have told us that the coronavirus pandemic has worsened children, young people's mental health. It's led in some cases to higher levels of anxiety, social phobias, depression. And we've also seen that some children and people have been adversely affected in other ways, such as criminal exploitation or involvement in gang violence. Across the visits, we've seen that the quality of pre-existing relationships, so between families and practitioners or between practitioners, been a really strong determinant of the experience of children, young people and their families during the period of the pandemic, but also affected how involved children, young people and families were in making decisions about how best to support them. And we've seen examples of where that's worked well, where their views and experiences have been heard and valued, but also where that hasn't worked well, and where that has often been worked less well when those families were more vulnerable, more isolated, less well connected into the resources and support in the local area prior to the pandemic. We've seen many examples of services adapting their approach during this time, countless examples of individual practitioners going the extra mile. I think, as was picked up in the chat earlier, we've heard about children and people who've had positive experiences from this move to working online, examples of access to appointments being better, those children, young people enjoying being educated at home, professionals finding working together more effective. But also we can see that many children and people with SEND, especially those with education, health and care plans, haven't returned successfully to education during this time. Levels of absence for that group of children and people are consistently higher than those for other school-age pupils. We've seen some links between patterns of attendance, children and people having more significant health or medical needs, or attendance in areas where coronavirus infection rates are higher, but also attendance being impacted by things like arrangements for home to school transport, and difficulties with transition back into settings or transitions from one setting to another setting during the period of the pandemic. For those children who have returned to education, we've got an emerging picture of what the curriculum has been like for them. So everything they experienced during the school day, not just the things that are formally taught, but I think some key elements of that have been about children and people being on part-time timetables. There's been a focus on the core subjects, English and mathematics, problems with following hygiene requirements in some subjects such as PE or design technology, the loss of important out of school and enrichment activities, so things like work experience, work placements, the opportunity to work and learn in the community. So the kinds of things, when you start to take them all together, have a real impact on children and people's ability to transfer and generalize what they're learning in school in important functional ways in their lives. And of course, those are essential elements of preparing well for adulthood, aren't they? We've heard examples of children and young people not accessing the specialist support that they had done previously. So the things that children and young people rely on for their physical health and well-being and their communication, the development of their communication and interaction. What leaders and practitioners have told us more generally is that they found the pace and the scale of change during this time particularly challenging, and I suppose the continued uncertainty about the progress of the pandemic, they've said has made planning in the medium and long term extremely difficult. What we've also found is that our colleagues in schools have found this period professionally and personally difficult in many ways, and we recognise and want to give real value to the way that that colleagues have worked, the tireless way that colleagues have worked in this time to provide support for children and people and families, sometimes to the detriment of their own health. But the feedback that we've had from these visits has been positive, and suggests that the case study approach that we're using in these visits, alongside the work that we've done to get a wider picture of what the SEND system is like in an area, has provided important insights, and in some ways gives us some assurance that we're at least going some way towards our objective of supporting improvement in this time. And I suppose that just brings me on to the next, my final slide, and the next stage, really. We've said that we will restart our programme of area SEND inspections when it's right to do so, and I'm sure you know that government have commissioned Ofsted and CQC to develop a new area SEND inspection framework to launch after the current programme of inspections has been completed. And importantly, that new framework will introduce a continuous cycle of inspections. So you may have picked up from HMCI's commentary and from the evaluation report we published in July about the current area inspection framework, is that we've had a concern about the stop-start, the sometimes stop-start impact of our current approach, where we see that sometimes the impetus for change and improvement in SEND arrangements isn't sustained, and that the sometimes reactive approaches can lead to actions which focus on the short term rather than things which are long term and strategic. We've said that we want to focus more on the lived experience of children, young people and families, and we're testing out some of that thinking through the case study approach that we're using on the interim visits. And of course, and great that Yvette's here today as well. We want to ensure that the care and social care contribution to the local SEND system it features much more prominently, and how well that is commissioned, integrated, provided is going to be a key part of our future approach. As you'd expect, we're reflecting on what we've learned through area SEND inspections so far when we're thinking about the future, the new cycle. So in thinking about focus and methodology for those inspections, we're considering things like whether all leaders in an area have an ambitious, realistic, shared vision for children and young people with SEND as a fundamentally important starting point. How well leaders, practitioners, children, young people, families work together to co-produce decisions, and not a coincidence that that's one of the main themes of the interim visits. What are co-production and collaboration like in the SEND system right now? That we want to look at the quality of universal and targeted education, health care and social care services. So as I've said, the things that when they're working really well, prevent children and young people from needing something additional or different, and what the graduated approach looks like at those very early stages of the continuum of need. As you'd expect, things about commissioning, planning, decision making, and the extent to which those things are working well, and ensure that children and young people are getting the right help and support at the right time. And importantly, and this is, I think, has featured significantly in our learning in recent weeks and months, the extent to which this is all of this, when you take it in the round, is really building towards something meaningful and ambitious and aspirational for children and young people with SEND, in the way that they are prepared for the next stage of their adult lives. I'm just going to conclude, Amanda, by saying that we want all of our work, our visits, our inspection activities, to make a difference to children and young people with SEND, and for the things that they experience through their childhood and their young adult lives, preparing them well for their adult lives in the places where they will live and work, in terms of their preparation for further education, employment, being independent, being as visible and included as they possibly can be, and of course being as healthy as they can be. And I suppose, and it's one of the reasons for being here today, and this being part of, a much bigger conversation that we're having with stakeholders. We want to take time to listen to all of our stakeholders to ensure that we really understand children and young people and families' experience, and that in constructing our future approach, we always focus on the things that do and will make the biggest difference to their lives.
Thank you so much.
I'll pause for breath.
Thanks, Nick. Do you want to stop sharing your slide so people can see you?
I will do.
And we will. So just so that people know what I'm doing with the timetable, I put in a 10-minute changeover break between the workshops. So what I'll do is I will run this session. So we'll have a whole 4 minutes for questions and answers with Nick. And then Marie will put up the evaluation for those people who aren't going into workshops. Then if we start workshops at 11:45, run them till 12:25, and then we'll still have a 5-minute break in between them and still finish on time. So without further ado, there were 3 questions I thought we should try and address if there's at all time. Nick, there was a question about just sort of whether you had any comment on the fact that some schools ask children, young people with SEND to stay at home during inspections, and what can be done about that. Whether, and I think this might be too long, but maybe you could sort of tell people where to find the examples, but examples from mainstream schools, approaches that are particularly helpful for supporting children and people with SEND. That was from Raj Mistry. And then I think I do need to get Juliet to ask her question herself, because I don't think I quite understood it. Oh no, that was the one. So yeah, so Juliet's question was about the Ofsted and CQC inspection focus on public health guidance engagement for all children and young people, and just how challenging the physical activity levels are to achieve for those children who tend to be taken out of PE to do their therapies and things like that. So I'm really sorry, I won't call on the people to ask the questions. I hope I've reflected those well enough. Nick, could you just sort of spend 2 minutes reflecting on those? Thank you.
Yeah. So in response to the first question, what I would say is that the education inspection framework, so the new school inspection framework that was implemented from September 2019. At the heart of that framework is the quality of education judgment. And in the introduction to the quality of education judgment, it makes it absolutely clear that when inspectors are gathering and evaluating evidence about the education that a school provides, they are taking a rounded view of what is provided for all children and young people, including those who have a special need or a disability. And I think I would, and you would expect me to, wouldn't you? I would argue that the EIF is a real force for good in children and young people's lives, especially those with SEND. And it makes it absolutely clear in the leadership and management judgment that schools should have an inclusive culture, and schools should have systems for identifying, assessing and meeting the needs of children and young people who need something additional or different. So I hope that answers the question. I think in relation to examples of good or emerging practice in relation to SEND in schools, one of the things that we know we need to work on and think about in developing the new area SEND framework is how we integrate what we have learned about the experience of children and young people with SEND from all of our different inspection and regulation work across Ofsted and CQC, and I think by doing that we will get better insights into what isn't working. I would have to say that from personal experience, the case study approach that we have used in the interim visits, I think, has given deep and very rich insights into the reasons why for some children and young people with SEND and their families, things are working well, and the things that haven't worked so well for others. So I hope you could see why we're giving such thought to incorporating that into any future methodology. And I think the third question someone was going to ask, Amanda, is that right? Sorry, I think you're on mute.
Thanks, Nick. It was the one from, I think, Juliet, which was about how you managed to meet the physical engagement targets when actually for children and people with SEND, when they're often pulled out of PE to do therapy sessions and additional learning.
I guess what I'd say on that, Amanda, is that my background is I was a teacher and a special school head teacher, and all I would say to that is that as a head teacher you make a lot of important decisions. The most important of those decisions are what you're going to teach and how you're going to teach it. So things about the whole curriculum. What is it essential for children and young people to learn in order to be best equipped for their young adult and adult lives? And I think what I would say is there are always competing tensions with those things. But it's essential, isn't it, that leaders use the time and practitioners in schools use the time they have in ways which best equip children and young people with SEND with the knowledge and the understanding and the skills that they need to be successful. And I guess a lot of your colleagues will know that those decisions are so much more important for children and young people who have any kind of difficulty with learning. And I think about the children and young people I've spent most of my professional life working with, those who have profound and multiple learning difficulties. You just cannot afford to get those decisions wrong for those children. They just haven't got time to work on things that aren't going to be important to them in the future. And a great colleague of mine kind of summed this up really well for me, and then I'll be quiet then. And as a new teacher. As a new teacher in the school that I was head of, he said, at the beginning, he didn't really have much of an idea about how he was going to fill up the day for a group of children with very complex needs in meaningful ways. And as he learned his craft and got better and better at what he realised that there just wasn't enough time in the day or in any number of days to do all of the things that those children needed him to do with them in order to learn well and achieve great outcomes. Oh, I think you're still muted, Amanda.
Okay, so basically I've got a monsoon going on outside, so I've been muted, and also I've been trying to do the thing in the chat, and then that's really noisy. So there are some questions in the chat. Nick, is there any chance that you've got 5 minutes just to answer in the chat so that we can finish the session and let people go because they're desperate for a break?
Yeah, of course.
Is that all right?
No,
Thank you.
I spotted a couple of practical questions there. I'm just wondering, Amanda, if I just put my email address into the chat, would that be helpful?
Oh, that would be great as well if anyone can follow up with
directly.
But if you could definitely answer the one about what's happening with the future of inspections, otherwise Leslie and Jill will kill me.
That's the one. That was the one that.
and it's nearly Christmas, so I don't want that to happen. Right, okay, I failed because we're now at 11:45, so I'm still going to give you a 5-minute break. That does mean that we're kind of going to miss a break during the workshop changeover, so I'm really sorry if I've called it wrong, guys, and I should have cut off NHS England, but they just had so much that they were trying to tell us, and it all seemed really helpful stuff, so I didn't. So do give me that feedback if that's what you need to do. Thank you so much, Nick. I can see in the chat that people have really valued what you've said, and we've had a request for your recording to go up on our website, so and to share the slides, which is always a good sign, because it means people really want to share it wider as well. So thank you everybody for coming to this. Thanks for bearing with us, and I normally, as those who know me, normally I am a stickler for timing, so I'm incredibly sorry that we've overrun. Yeah, Marie will now put up, for anyone who has to leave, can't join the workshop, if you can just spend a few minutes doing the feedback by the poll. If it will be easier for you to do it by the just to do it by the link, then Marie will also put the link in the chat. So workshops starting at 11:50 and finish, the first one finishing at 12:30, and then the second one running 12:30 till 13:10, and you still finishing at 13:10. Thank you all very much indeed. Are you all right to put that poll up, Marie?
Hi, Amanda. We've decided I will share.
Oh, okay, so Daphne's going to.
Because I'm not facilitating for the first session.
That's fine. And if you can just put the link in the chat, because then even if people are already leaving, Daphne, they can they can still see it in the chat. So I'm going to leave now because I have got to go. I probably should be letting people into a workshop very soon, and I need to grab a drink. So see those of you who are doing the data workshop very shortly.